Welcome to NP Certification Q&A, presented by Fitzgerald Health Education Associates. This podcast is for NP students studying to pass their NP certification exam. Getting to the correct test answers means breaking down the exam questions themselves. Expert Fitzgerald faculty clinicians share their knowledge and experience to help you dissect the anatomy of a test question so you can better understand how to arrive at the correct test answer. So, if you're ready, let's jump right in.
The psychiatric mental health nurse practitioner is evaluating a patient who presents complaining of panic attacks that occur for no identifiable reason. The patient has been treated for these previously with a variety of pharmacotherapies that did not provide any meaningful improvement. Upon further conversation, the NP learns that the patient experienced a near-fatal bicycle accident 4 years ago after being hit by a car. When considering a diagnosis of post-traumatic stress disorder, the NP explores his history for all of the following diagnostic criteria except A. Intrusion symptoms, B. Angry outbursts, C. Negative cognition, or D. Avoidance symptoms. And so, this clearly is a question about diagnostic criteria. What are the diagnostic criteria for post-traumatic stress disorder? And you're not expected to be able to articulate every single detail of every single area, but you are expected to know the basics of what should be there for diagnosis. And so, for this question, B is the correct answer. Angry outbursts are not among the diagnostic criteria. Diagnostic criteria for PTSD minimally requires the history of a traumatic event. And that traumatic event, if you look at the DSM-5-TR, the traumatic event is either experienced directly by the patient or they witness an event that happens either at them or to a close, a friend, family member, or loved one. In reality, what that traumatic event is really can differ from person to person. Something is traumatic if it's traumatic to the patient. So it may not necessarily seem like something that is traumatic to you, but is traumatic to the patient, and that's what matters. I have had patients that have truly, honest to goodness PTSD following a really contentious divorce. I've had patients who have PTSD, not after one, major traumatic occurrence, but a cumulative effect of things. And so, again, this level of detail is not something you need to perseverate over for your boards. What you do need to know is A, there must have been a traumatic event experienced or witnessed. Okay, well, we have that in this, the near-fatal bicycle accident. But what else? When you look at diagnostic criteria for post-traumatic stress disorder, they do include minimally the things that are listed here. At least one intrusion symptom. Intrusion symptoms are those things that basically amount to re-experiencing by the patient. Either recurrent, involuntary, intrusive, distressing memories. Again, intrusive, involuntary. They just pop up out of the blue when the patient's not expecting it. Recurrent, distressing dreams. Even dissociative reactions like flashbacks. Physiologic reactivity like, tachycardia, tachypnea, palpitations, etc. when they're exposed to some sort of reminder. So intrusion symptoms can be many things, and you don't have to remember them all, but you do need to keep in mind that there needs to be at least one intrusion symptom. Similar, at least one avoidance symptom. And again, avoidance symptoms can be many things. Some people avoid memories, avoid feelings. When they start to feel a certain way, they very purposely divert. Others avoid external reminders, like they will purposely put away pictures, memorabilia. They avoid driving by certain places or traveling to certain places or whatever. So you've got your intrusion symptom, your avoidance symptom, at least 2 negative alterations in cognition. Alterations in cognitions are things like a perpetual negative emotional state, feeling detached or estranged from others when they didn't previously, not being able to experience positive emotions, loss of interest or pleasure, things that can very often sound like depressive symptoms. And then also there needs to be 2 changes in arousal and reactivity. Things like irrational, angry outbursts for no reason, an exaggerated or startle response, sleep disturbances. So again, I want to emphasize here that you don't need to memorize every example of everything. But with PTSD, many times it presents as anxiety or what the patient thinks of as a panic attack. And yet when you start to do your evaluation, it doesn't really fit those criteria. If you're considering PTSD, look for a traumatic event history, and then minimally 1 intrusion symptom, 1 avoidance symptom, 2 negative changes in cognition, and 2 changes in arousal and reactivity. And then it really is a fair impression that there is PTSD here. And at that point, it's time to refer the patient to a therapist.
Thank you for listening to NP Certification Q&A, presented by Fitzgerald Health Education Associates. Please rate, review, and subscribe to this podcast. And for more NP resources, visit FHEA.com.